Okay, so now we're going to take a look at hepatic abscesses. Now, with hepatic abscesses, we pretty much have three types. One is a bacterial one, also called pyogenic. Then there is a specific amoeba, which will cause the amoebic abscess. And this is going to be the Entamoeba histolytica. And then you have the Hydatid abscess. And I think I'm just going to take them one at a time. So this is going to be primarily bacterial. Which bacteria? This can be, the most common one is E. coli, but you can also get Klebsiella. You can get strep, pneumonia. And then some of the anaerobics, such as Bacteroides. And with with amoebic abscess, there's only one. It's only Entamoeba histolytica. And with Hydatid, we're only going to be looking at the Echinococcus, which is the tapeworm. Okay, so let's start with the pyogenic first. So pyogenic is pretty much, in a nutshell, when you get a bacterial abscess formed in the liver. So what are the different, how do you get a bacteria? Wow. There you go. How do you get a bacteria to get into the liver? Where there's three primary routes. One is going to be from the portal vein. So the first way is from the portal vein. So this is basically going to be anything from your GIT tract. So the portal vein is going to go into different parts of your liver through that area. Now, what kind of infection would you have? This is going to be some type of appendicitis, and the infection jumps into the veins, and it can even be diverticulitis. And these are the two common ones, but there's obviously going to be much more. Then the other one is going to be via the biliary tract. So this is most commonly due to cholangitis. So you have your biliary tract, you get a cholangitis here, and then you have your gallbladder, and that can also cause it to go up that way. And finally, you can have it through hematogenous spread. And this is going to be anytime there's bacteremia or anything along those lines. And that's going to be through the, that's going to come from, I'll use a different color, that's going to come from the celiac trunk, and it's going to go up into the liver. Now, of course, you have two other ways. One is going to be to trauma, and the other one, is going to be pretty much unknown. They call it cryptic, and actually 50% of the times, it's going to be cryptic. So this is the general etiology. Now, what do you see when a patient has hepatic abscess? Well, I kind of break it down into a few ways. First, I kind of look at it of the infectious, the symptoms of infection. So they're going to have all the symptoms of infection. And what is that? That's going to be your fever, your every time you have fever, you're going to have your constitutional symptoms, weakness, weight loss, anorexia, all that, and nausea, vomiting, and of course you're also going to get leukocytosis. And so these are the signs related to the fact that you have an infection. Then the other symptoms are going to be related to the liver and bile. So whenever you have problems with your liver and bile, you're always going to get a certain types of symptoms, and this is primarily your right upper quadrant pain, which it radiates, right? Radiates to the intrascapular or the, just to the back area, or to the left shoulder in the back. You get some jaundice. Obviously, this is going to be, and then you're going to get tender hepatomegaly. And these are going to be symptoms that we're going to find in all of them, whether it's pyogenic, amoebic, or hydatid, and then we'll focus on other, different symptoms and investigations, how you can differentiate them. Now, in this, and if you also notice, right upper quadrant pain that radiates in jaundice, that could also be cholecystitis as well. However, just one thing to point out is in this situation, it's more severe, and actually actually not necessarily more severe. I'll take that away, but it's just the patient looks toxic. The patient looks really, really ill, really sick. Now, what kind of investigations? What kind of investigations would we do? The investigation that you'd want to do, first, of course, this is a problem with the liver, so you're going to do your liver function test. And they're all going to be elevated. You're going to have elevated AST, ALT, you're going to have elevated ALP, your bilirubin will also be elevated. Your albumin level be low. You have a huge infection. Obviously, you're going to have all these symptoms. But the investigation that will really show you what you have is going to be the ultrasound. And what you'll see in the ultrasound is a hypoechoic mass. And what's even better, what's actually the investigation of choice is the CT scan. And let me see the CT scan. If you go here. So here you can see this CT scan, and you see how evident it is right here. Huge abscess sitting right there, and so that's how you can see that. And then the other thing that we do want to do as well is we want to do a chest X-ray, and this actually goes for all the abscesses. They all can cause pulmonary symptoms, so we do need to see a chest X-ray. And what you might find is signs of pneumonia. And you might find, maybe air under the diaphragm. Now, how would you treat this? The treatment is a bacterial infection. So, obviously, the first thing we'd want to do is we'd want to just automatically give some course of antibiotics. You'd also want to do, you can attempt a percutaneous aspiration, and then this can, you can take this, culture it, and then, do sensitivity on it. And this should be ultrasound or CT guided. And finally, if, all else fails, or if it's really big, you can do surgery to remove or to drain the abscess. Okay, so that's going to be with the pyogenic. So the next one we're going to go to is the amoebic. So in the amoebic, like we discussed before, this is called Amoebic histolytica. How do you get it? It's due to food that's contaminated with feces of the cyst, and the cyst will go into the cecum. I actually have a decent diagram here. So what happens is with Amoebic histolytica, you have the cyst will go down into the intestines and then get absorbed. And at the cecum, it'll start growing. And then from the cecum, it goes into the mesenteric vein, goes into portal vein, and then it goes into the liver. And from the liver, it can shoot into the lungs. It can go into the peritoneal area. It can even go up to the brain, heart. It can go into many different areas after that. Now, when we're looking at the so we can just delete that. When we're looking at the clinical symptoms, what you'll find is it's going to be the same thing as with regards to you have signs of infection, which is going to be your fever, constitutional symptoms, and leukocytosis. You're also going to have your symptoms related to the liver and bile. So that's going to be your right upper quadrant pain that radiates, jaundice, tender hepatomegaly. But there's a few extra symptoms that you don't see. So these you're going to get in both amoebic, hydatid, and pyogenic bacteria. But here, 3 symptoms that you might not see in other ones. First of all is diarrhea. And again, if you recall, it goes first into the cecum, and so then the patient might have some symptoms of diarrhea. The other one is cough. Now, all of them can have cough and pulmonary symptoms, but this will have an anchovy. This can possibly have an anchovy paste phlegm, I guess you can say, coming out of it. And that suggests, if you do see that, that suggests a bronchopleural fistula has developed. And so obviously this is a more serious sign. And finally, the Entamoeba histolytic, 95% of the time, there is some history of travel within 5 months to an endemic area such as South America and India and some of the other Asian countries. Now, let's now take a look at your investigations. Again, it's a problem with the liver, so of course, your liver function test, everything would be up. The same as in pyogenic. Now, ultrasound, you're also going to see, some type of abscess here, and even CT scan. But those aren't enough to clearly differentiate. Do we have? Let me just write chest X-ray as well. It's not enough to clearly differentiate whether you have pyogenic. So what you could do, since it's found in the cecum, this is not always the case, but sometimes when you do a stool, you get the stool, you could do microscopy. Now, microscopy is, well, first let's talk about stool. The problem with stool is it doesn't necessarily mean that they have amoebic colitis. They can have, some problem with the liver, and the colon has cleared up or it's no longer there. So you might not even find anything. And if you look under microscopy, there's so many other organisms that are similar, or they're not going to cause any disease, and so you can't really differentiate the two. So what you could do is you could try looking for the stool antigen. The only issue with this one is you need a fresh sample, so that kind of holds you back. Then the other one is you can culture it. Unfortunately, this is a good idea, but this is limited. You're oftentimes limited in availability and where you can do it. And finally, you can do serology testing for this as well. Now, with as far as treatment, the treatment is a little bit more straightforward. It is a protozoa, so it's still going to respond to not mebendazole, metronidazole. It's gonna respond to metronidazole. This is effective in 90% of the time. However, for that 10%, you would need to go to surgery for aspiration. Now, for the final one, so we've done the pyogenic, we've done the amoebic. Now let's go to the final disease that causes abscess, Hydatid. So Hydatid is caused by the Echinococcus granulosus, like we discussed before. How do you get it? It's basically you drink food or water that's been contaminated with dog feces. And clinically, what do we get? Now, these can come in all different shapes and sizes. So if it's, first of all, if it's really small, it's usually asymptomatic, but usually once it gets to 5 centimeters, you will start to see symptoms. Now, kind of going back to the other theme of these symptoms, the symptoms are going to depend on where it is, the location, how big it is, and what it's, and basically it's the mass effect. It's just taking up space, and that's where you're causing damage. So, for example, if it's found in the liver, well, what are your symptoms going to be? Well, we already kind of went over that. Right upper quadrant pain, jaundice, and obviously you can expect to see, your liver function test and everything higher. What if it's found in the lungs? Well, of course, the patient is going to present with some type of cough, maybe even hemoptysis, and other symptoms. If he gets pleural effusions, symptoms related to that. How about if it's found in the heart? If it makes its way to the heart, then what can you expect? Probably a pericardial effusion. And again, other symptoms related to the heart, depending on where it is. And finally, probably one of the most serious ones, if it's found in the brain or spine, then depending on where it is, what level it's on, you're going to get neurological deficits. What would be the investigation that you would do? When it comes to labs, they're not so specific. You could do serology for it if you're really looking for it. But the method of choice here is going to be the ultrasound. And this is because you can see many, and also, CT scan and MRI do help. They have certain advantages for seeing certain things. And I do have I believe this is a CT scan. It's not working. Okay, okay, it's not moving over here, but there's a CT scan. What you tend to see, I can just draw it out. You have this here, and you have multiple cysts sometimes, and within the cysts you have the trophozoites of the Echinococcus granulosus. So now, finally, what is your treatment? You're going to use an antihelminth, the albendazole, endobendazole. They tend to work pretty well. If not, you would, so that's your first treatment. Second would be, you can do something called PAIR, PAIR, and this stands for puncture, aspirate, inject, and re-aspirate. This is a little bit risky because when you puncture, and if the cysts get out and it ruptures, and that can cause anaphylaxis. So the big worry here is anaphylaxis. You don't want to. You want to be very careful if when you work percutaneously or when you do surgery. And of course, if all that doesn't work, or there's too many cysts, or it's too big, then you're going to just have to do surgical resection. And again, any type of surgery that you do, you want to be careful rupturing, because that can lead to anaphylaxis.